All right, in this one, I call this one no pulse, no problem. Um, I'll give you my objectives. So this, I kind of built off of the case I posted on Instagram this morning. If you didn't catch that case, I have it in the next slide. So we'll go over it. But we're gonna discuss what pulseless electrical activity is, how we treat it, what are some common causes of it, what are shockable rhythms, how do we deal with like potassium handling physiology, and then what's the management of hyperkalemia. That's gonna be the bulk of our talk. We'll see how quickly we can get it done. Very, very important concepts covered in this lecture. Hyperkalemia management like really occurs probably in every exam you're probably ever going to take, just like I talked about with like TTP yesterday. So hyperkalemia is super important, so make sure you're paying attention. So this was our case that I posted on Instagram. I'll reread through it quick. We have a 60-year-old man in cardiac arrest is brought to the emergency department by paramedics. Bystanders initiated CPR within minutes of his collapse. Paramedics say his initial rhythm was pulseless electrical activity when they arrived at the scene. En route to the hospital, paramedics continued CPR and obtained a supraglottic airway. 3 doses of epinephrine were administered. No medical history is available. On arrival, CPR is continued, and the first rhythm is PEA. The supraglottic airway is functioning appropriately. Auscultation of the lungs discloses coarse breath sounds bilaterally. On a brief secondary survey, an AV graft is noted in the patient's left arm, and he has had a right-sided below-the-knee amputation. There are no signs of trauma. Fingerstick blood glucose concentration is 312. What should we do for this patient? So if you didn't get a chance to think about this question, you can pause the screen, think about it now, and then we'll move on to the next section. So in this one, we would give some form of IV calcium, right? So it's going to be calcium gluconate or calcium chloride. There is nuance here, and we're going to discuss that nuance near the end. Before I explain why calcium chloride or calcium gluconate in this patient, we've got to talk about some physiology and pathophysiology first, so we fully understand what's going on in this case, so we can really come into this answer having a great background of information, so then the answer makes sense. Okay, so what is PEA anyway? So PEA is an organized EKG rhythm that should generate a pulse, but there's no palpable pulse or effective cardiac output, okay? So the EKG will look normal, or at least you'll see something on the EKG, but the patient isn't gonna have a pulse, or they're not gonna have cardiac output. This differs from asystole, which I showed you on this EKG strip, where we literally don't see any electrical activity in these patients at all, okay? So asystole is no electrical activity, and then there are some things like shockable rhythms like VFib or pulseless VTAC that we're going to talk about in a second. So my question for you is, can I initiate defibrillation in a patient with PEA? So again, in PEA, you'll see electrical activity on the EKG, but the patient won't have a pulse. Can I shock them? So PEA is classified as a non-shockable cardiac rhythm. It's a cardiac arrest, and management will focus on high-quality CPR. Potentially, you can use epinephrine, right, like they did in the vignette, but really CPR is going to be the backbone of treatment here. So my next question, I kind of spoiled it a little bit, but you can really think about these a little bit more. What about asystole, VFib, or hemodynamically unstable VTAC? Are any of these shockable rhythms? So think about that. So the American Heart Association states that defib is indicated for VFib and pulseless VTAC. Okay, so we can shock, we can do defibrillation for both ventricular fibrillation and pulseless VTAC. Okay, these are the classical shockable rhythms. In contrast, asystole and PEA do not benefit from the defibrillation and their management with high quality CPR and trying to reverse any identifiable causes. Okay, so again, kind of in your buckets here, we're going to put shockable rhythms and non-shockable rhythms, okay? So my shockable rhythms would be things like ventricular fibrillation and unstable or pulseless VTAC. My non-shockable rhythms would be things like PEA and asystole, okay? Classic USMLE step 2 question. They'll give you one of those. Maybe they won't tell you, and you'd actually have to read the EKG. That's going to be a story for another day. I'm going to do several different like EKG lectures. It's just too much to cover in these lectures built on other topics, but they would give you the EKG and say, what would you do next, right? If it's ventricular fibrillation or if it's VTAC without a pulse or they're hemodynamically unstable, defib, okay? If it is PEA or asystole, CPR, okay? So my next question for you is, what's the difference between defibrillation and unsynchronized cardioversion? So take a second, pause your screen. So there's nothing. There's nothing different between defibrillation and unsynchronized cardioversion. They are the same things, right? So the shock is delivered at any point in the cardiac cycle, right? So it's unsynchronized. Okay. That's different from synchronized cardioversion, where the shock is timed with the R wave. So again, in defibrillation or unsynchronized cardioversion, we give the shock at any time, right? There's no synchronization to the cardiac cycle. And it's used in pulseless VTAC and ventricular fibrillation, right? We've literally talked about this. Now I've said it multiple times, so hopefully it's starting to sync. There are no organized rhythms in VFib or pulseless VTAC for us to synchronize to, okay? So that's why we're going to use unsynchronized cardioversion here. Synchronized cardioversion, the shock is timed to the R wave of the QRS. It avoids the T wave, right? So we can get ourselves into a whole bit of trouble if we shock during the T wave, because that's a really vulnerable period where the cardiac cycle is going back through repolarization, and we can start another rhythm where we shouldn't have a rhythm, and that can lead to instability of the whole entire cardiac membrane and can trigger ventricular fibrillation, okay? Synchronized cardioversion can be used for atrial fibrillation with a pulse by the American College of Cardiology and AHA guidelines. That, again, AFib will be its own lecture. I've got a lot to teach about AFib, so I'm covering that in a whole different lecture. But synchronized cardioversion can be used for AFib. And so this really matters, again, like the synchronized cardioversion, because inappropriate timing during the T wave can induce ventricular fibrillation. So again, a classic like USMLE step 2 question would be like the patient would get some sort of shock, and it would send the patient into ventricular fibrillation, and they could ask you, where did we initiate the shock, right? It would be somewhere. The answer would something say about the T wave or during the repolarization of the cardiac action potential, okay? That's probably a little bit too advanced for a step 1 question. So again, defibrillation is the same as unsynchronized cardioversion. We do a shock at any point in the cardiac cycle. It's used for pulseless VTAC and ventricular fibrillation. Synchronized cardioversion, we shock in rhythm with the R wave. We avoid the T wave because that could trigger ventricular fibrillation. All right, moving on. So this is from AMBOSS. I think it's a really nice like ACLS protocol. I kind of narrowed it down. We don't need to see the full thing. But really, if you see an unresponsive adult, we want to start CPR. We want to call for help, right? We've all had to do the ACLS, like the CPR classes. So you all know how to do that. But once we attach a defibrillator, we'll analyze the rhythm as soon as possible. If it tells us it's a non-shockable rhythms, what were my non-shockable rhythms again? They're going to be asystole and PEA, right? So there they are there. We're going to continue CPR, and if possible, we'll give epinephrine as soon as possible, right? And we can repeat that every 3 to 5 minutes. We're going to then check for signs of return of spontaneous circulation. If they don't have return of spontaneous circulation, we're just going to keep going again. CPR, epinephrine every 3 to 5 minutes, right? Boom, boom, boom. If the defibrillator showed a shockable rhythm, right? So what were our 2 big shockable rhythms we talked about? We talked about ventricular fibrillation and pulseless ventricular tachycardia. We're going to initiate a shock, right? So the initial dose is like 120 to 200 joules, and we can increase as needed. After that second shock, so defibrillation is always the first step, right? After that second shock, then we can give epinephrine every 3 to 5 minutes. After that third shock, we can give amiodarone or lidocaine, right? So again, the classic question, they'll give you a patient, CPR is always going to be like, we're going to start with CPR until we get the defibrillator, but then they'll put the defibrillator on the patient. It'll show a shockable rhythm, right? So they'll tell you VFib, pulses VTAC, they'll show you a EKG, and they'll ask, what is the next best step? They'll have on there probably epinephrine and amiodarone and shock them, or they could say like unsynchronized cardioversion. You're going to pick unsynchronized cardioversion or defibrillation, whatever word they decide to choose, because that's our first step is defibrillation. Then after that second shock is when we can consider epinephrine. After that third shock is when we can consider amiodarone or lidocaine. Just refresh me here. If I give amiodarone, right, what is the mechanism of action of amiodarone? So think about that. So amiodarone is one of those unique antiarrhythmics. It's classically described as a class 3 antiarrhythmic, but it actually has properties of class 1, 2, and 4. Okay. If I give a patient amiodarone, let's say I want to put them on long-term amiodarone, what things should I check before, during treatment? So on a patient on amiodarone, we want to check PFTs, LFTs, and TFTs. Okay, it's associated with pulmonary fibrosis. Different, it could cause both hyper or hypothyroidism type symptoms and presentation, and then it can also cause elevated liver enzymes and liver damage. Okay, amiodarone contains a iodine molecule, an actual compound, so it can mess with your thyroid. That's the whole mechanism there, and it kind of depends on what the thyroid does with that iodine to determine is this going to cause hypo or hyperthyroidism symptoms. It can cause both if you look at the literature. So again, we do CPR, we analyze the rhythm non-shockable, asystole PEA. We're going to give epinephrine every 3 to 5 minutes and just continue the CPR epinephrine until we get that return of spontaneous circulation. If it is a shockable rhythm, right ventricular fibrillation, pulses VTAC, we administer the shock. After the second shock, epinephrine. After the third shock, amiodarone. Okay. So I want you now to consider what are the broad causes of PEA. Okay, there's a really cool mnemonic for this. There's 10 total causes, but see if you can pause your screen and come up with as many of those 10 as possible. They're just broad buckets. So they're the 5 H's and the 5 T's. Okay. So my H's stand for a hypovolemia, hypoxia, hydrogen ion, hypo or hyperkalemia, and hypothermia. My T's stand for tension pneumothorax, tamponade, so cardiac tamponade, certain toxins, thrombosis, and also thrombosis, right? So pulmonary thrombosis, coronary thrombosis. I don't use Anki too much. Like I don't think you should rely on memorization, but this is one of the instances where you could easily throw this into an Anki card, work on it for a couple weeks to a month, and you can just have this memorized for the rest of your life. Understanding these 5 H's and 5 T's will be really important when you get a patient in your life who has PEA, and you have to find the cause really quick to make sure the patient doesn't die. All right. So the American Heart Association and the Society of Critical Care Medicine recommend systematically evaluating for these causes during resuscitation. So what are we going to do? How are we going to look for these causes? Well, if the patient is hypovolemic, right, we're going to look for a history of fluid loss. Do they have bleeding, vomiting, diarrhea? What's their blood pressure, right? Do they have reflex tachycardia? What do their neck veins look like, right? Are they flat? Does that indicate, right? That indicates low blood flow, right? Do they have poor cap refill, pale and cool skin, right? Are they hypoxic? What does their skin look like, right? Are they blue? Are they blue around the lips? Are they blue around the fingers and toes? What's their oxygen saturation, right? Were they in respiratory distress or arrest prior to this PEA? Was there preceding bradycardia, right? Do they have a history of airway or respiratory compromise? For the hydrogen ion or acidosis, right? Look for those deep, rapid respirations. Those are called those Kussmaul breaths, right? That's because when I get a metabolic acidosis, right, our body is going to want to try to blow off the CO2, right? Because CO2 is like our acid, right? When CO2 builds up, it leads to respiratory acidosis, right? So if H plus is building up from a metabolic cause, it's going to tell our lungs, it's going to tell our brains and our lungs to work together to blow off that CO2. So you can get these really deep, rapid respirations to try to hyperventilate and blow off the CO2 to bring my pH back to normal. Okay, do they have a history of renal failure that could lead to this metabolic acidosis? Are they in septic shock, right? Do they have DKA? What's their pH on their blood gas, right? What's their mental status? All things to consider for a hydrogen ion. For a hypo or hyperkalemia, we can think about muscle weakness. We can think about arrhythmias, EKG changes. So we're going to talk about these coming up, but we could see peak T waves in hyperkalemia, widened QRS in hyperkalemia, and U waves for hypokalemia. Do they have a history of renal disease or diuretic use that could be messing with the way my kidneys handle potassium? For hypothermia, think about low body temperatures. Were they outside on a cold winter night? What do their extremities feel like? Do they have bradycardia? Do they have Osborne waves, which I'm going to show you a picture of? And do they have a history of exposure, right, being out in the cold? For tension pneumothorax, right now we're into the T's. Sudden respiratory distress, right? Remember, tension pneumothorax usually comes on pretty traumatically or like pretty acutely. Do they have unilateral absent breath sounds, right? When the lung collapses because of all this air that's stuck in the pleural space, you stick your stethoscope on that portion of the patient's back, you're not going to be able to hear anything because the lung is just collapsed. Do they have tracheal deviation from a huge mediastinal shift, right, and a massive tension pneumothorax? Do they have distended neck veins, hypotension, hyperresonance, right? So the distended neck veins and hypotension could be due to cardio collapse as well, from the lung pushing over into the mediastinum, collapsing the cardiac tissue from actually being able to collapse. So we get backflow of blood. It's pretty much like a tamponade type picture, right? And then remember, when there's air in my pleural space and I percuss on the patient's back, it's going to lead to hyperresonance. That's opposed to if a patient had like pneumonia or a pleural effusion, where it's a consolidation or liquid. If I percuss on their back, it's going to be dull to percussion, right? So hyperresonance on percussion, if you ever see that in a question, it should probably key you in onto some sort of pneumothorax. My next T is tamponade. So again, our Beck's triad, muffled heart sounds, distended neck veins, hypotension. We get a pulseless paradoxus where normally when I breathe in, my systolic blood pressure should drop by a little bit. If it drops by more than 10, that's considered pulseless paradoxus. Again, that's because when I breathe in, I'm bringing more blood flow back to the right side of my heart. And normally my heart should be able to be compliant and accept that and continue the blood flow forward. In tamponade, remember I talked about this in previous videos, but in tamponade, we have compression of the pericardial space and eventually leads to equalization of the diastolic pressures in my four chambers. And so if there's no difference in diastolic pressure, there's no movement of forward blood flow. So in this case, when I breathe in, when I inspire, there's an increase of blood flow back to the heart, but there's nowhere for that blood to go, right? So the systolic blood pressure is going to drop by more than 10 because there's nowhere for that excess blood to go, and my heart is not able to contract as well due to this equalization of the diastolic pressure, okay? If we're also thinking tamponade, do they have a history of trauma to the chest, or do they have pericardial disease, right? I'll go into tamponade. I did a lecture on chest pain. It's just being edited right now. So you'll learn about tamponade pretty soon whenever that gets out. When we think about toxins, do they have altered mental status, arrhythmias, pinpoint or dilated pupils, abnormal vital signs? Do we know if they have a history of drug ingestion or exposure, right? We can get a urine tox screen too. Pulmonary embolism, remember that's an acute sudden onset of dyspnea, chest pain, tachycardia, hypotension. We could see right heart strain on an EKG, so we could see right ventricular hypertrophy, right bundle branch block, right axis deviation. Do they have a history of DVT or immobility, right? So all things that could lead to PE, right? DVT or immobility. Are they on estrogen? Were they pregnant or recently pregnant, right? Do they have a family history of thrombophilia? Do they have a history of malignancy, or were they currently treated for a malignancy? Do they have one now, right? Kind of things like that are what I'm thinking about when I think about things that could predispose me to a PE. Do they have a family history of thrombophilia? Is actually like probably one of the most important ones that gets asked on exams, because it's not one that like totally comes to mind. Everyone always thinks about like immobility or recent surgery, right? They might key in on the question like mom had a history of a DVT when she was like 30 and then she had a PE when she was like 40, right? That keys me in that she might be like overclotting and this patient might have a thrombophilia as well, right? The most common thrombophilia is going to be factor V Leiden. I'm going to make a whole lecture on thrombophilia later this week that will go into all of those. Coronary thrombosis is another one, right? So chest pain prior to the arrest, diaphoresis, nausea, a history of coronary artery disease, and then our classic EKG changes like my ST depression or elevation, right? And then arrhythmias. Okay. So just some like pictures. Again, this is not meant to be an EKG lecture. I will show you when we do our EKG lecture, I'll have all these as examples because I think they're important. But in hypokalemia, we can get this U wave. So here's a little bit of a Q. There's the R. There's the S. There should be the T as a repolarization. The T is going downward, right? So there's my T, and then I get this extra hump, right? That's called my U wave, okay? That is a sign of hypokalemia. In hyperkalemia, we can sometimes get these peaked T waves, okay? So we don't really have a Q here, but R, S, here's my T wave, and it's nice and peaked, okay? We can get the peak T waves. The P waves can eventually flatten. The PR interval can prolong, and then we can get a wide QRS complex. I go more into this on the next couple slides. And then we have the J point, right? So the J waves that I talked about in hypothermia. The J point is where here's our Q, our S, where the S meets the T wave. Okay, so it's this point right here where the S meets the T wave. Okay, when the S point is, or when the J point is elevated, right? So I look at my isoelectric line. I usually like to use my PR interval as my isoelectric line. When that J point is elevated more than 2 millimeters, that's what we consider a ST elevation, right? But sometimes we can see this extra hump where the J point is, okay? And when we see those extra humps, that's called a J wave, and that can key us in on hypothermia. It's pretty specific for hypothermia. So if you ever see this J wave, always look for it, especially if the patient's history matches, right? Do they have some sort of hypothermia? We should look for the J waves, see if we can find it. All right. So now back to our patient. Can we pick out of those 10 causes which one we think they might be having that led to their PEA? So I took this from the stem. On a brief secondary survey, we see an arteriovenous graft is noted in the patient's left arm, and he has a right-sided below-the-knee amputation. There are no signs of trauma, and his fingerstick blood glucose is 312. So this is keying us into the fact that this guy likely has CKD. He has the AV graft, his AV fistula that he uses for hemodialysis, and this is probably secondary to poorly controlled type 2 diabetes. We know his blood glucose is 312, right? Poorly controlled. He also has this right-sided below the knee amputation. We don't know any more than that, but we can maybe assume that it's because of his poor diabetes. Like it might be diabetic foot disease. It could be peripheral arterial disease that led to an amputation. But this whole clinical picture, right, is pointing me into the direction that this guy is on dialysis and potentially he missed a dialysis appointment or two, and it's led to this hyperkalemic emergency, right? This is why our secondary survey, right? So like primary survey, like you're going to do your ABCs, airway, breathing, circulation. But the secondary survey, right? Once we get the patient a little bit more stabilized, looking and doing a quick physical exam can really help you. And in this case, right, it showed us he has this AV fistula. Me as the emergency medicine physician, right? If this were like our patient in the ED, we have to consider, okay, this patient might be having a hyperkalemic emergency. That's one of my H's, right? Out of my 5 H's, potentially we should treat that. Okay. So this is like the progression of what we can see on EKG in a patient with hyperkalemic emergency. So first we start with these peak T waves that I showed you the picture of, right? Seen at a potassium of, 5.5 to 6.5. Then we can get this PR interval prolongation. It's caused by slow AV conduction. We'll see a potassium of 6.5 to 7.5. We can then get flattening and loss of the T waves, okay? And eventually we might even lose them. We can then progress to widen QRS complex, and that's where I start to get really scared, right? The QRS is above 120 milliseconds. It merges with the T wave, and we can actually see a sine wave pattern. So if you remember back to like pre-algebra, how the sine waves look like hills, like up and down and up and down. When we see that sine wave pattern, we're in danger. We're in big time danger. It's seen at potassium of over 8 to 9. And then we can have ventricular arrhythmias, asystole, and PEA. So these are like the final rhythm of hyperkalemia. If we get to this point, it's very, very scary. It's a do or die situation. We got to act now. Okay. So peak T waves, PR interval prolongation, flattening and loss of the P waves, widening QRS and sine wave, and then eventually VFib, asystole, or PEA if we're not able to treat it. So a little bit on the potassium handling physiology, just because I think it's really important just for us to kind of understand how is potassium used in the body and like where does it go. So filtration, potassium is freely filtered at the glomerulus. It's reabsorbed about 65 to 75% passively in the proximal convoluted tubule along with water and sodium. In the thick ascending limb, remember that's where like things like furosemide, our loop diuretics work, and that's because we have these beautiful sodium potassium 2 chloride co-transporters, okay, that sit up there in the thick ascending limb. Potassium recycling into the lumen contributes to that positive lumen potential, and that positive lumen potential is going to try to push magnesium and calcium back through, it's called paracellular reabsorption. So in between cells, that positive charge is going to repel magnesium and calcium and back through these cells and cause reabsorption. Okay. So transcellular is literally like through the cell. Paracellular, I have two cells here, and we go right in between both of them. Okay. So that potassium that gets recycled in the lumen creates a positive charge that will repel magnesium and calcium back through this paracellular space to get reabsorbed. So that's our reabsorption secretion in the distal convoluted tubule and collecting duct. These are the principal cells that are going to secrete potassium in exchange for sodium, and they use these ENaC channels. So we reabsorb sodium, kick out a potassium, reabsorb sodium, kick out a potassium into the urine. Okay. The process is stimulated by aldosterone. Aldosterone increases the ENaC expression. It increases the apical potassium channels, and it increases the sodium potassium ATPase activity. Again, aldosterone's job, it keeps sodium in water. It kicks out potassium and H+. Okay. Our alpha intercalated cells can also reabsorb potassium via the H+ potassium ATPase, especially during hypokalemia. Hormonal regulation, I already talked about aldosterone. Antidiuretic hormone kind of has more of like a passive effect, just because it's going to increase water reabsorption. And so that can mess with potassium concentration a little bit. But really, if you're going to remember a hormone that has to deal with potassium, it's going to be aldosterone. Okay. Aldosterone keeps sodium in water, pumps out potassium and H+. So pathophysiology highlights, right? When I'm thinking about hyperkalemia, it's usually caused by a decreased renal excretion. So maybe the patient has kidney failure or low aldosterone, right? So if there's low aldosterone, the potassium is going to be high, or there are transcellular shifts that are shifting potassium out of cells, out into the extracellular space. In hypokalemia, it's often due to increased renal loss. So things like diuretics and hyperaldosteronism. And then just a reminder to you, the normal potassium level is usually about 3.5 to 5. And then the sodium potassium ATPase will pump 2 potassium ions in and 3 sodiums out. Okay. So potassium's really high in the intracellular space, pretty low in extracellular space. All right. So some hyperkalemia key causes and can't miss diagnoses. The most common and high yield causes would be due to a lack of renal excretion or low renal excretion. So things like CKD and AKI, they lead to a low GFR. If the kidneys aren't being perfused, right, it's going to lead to kidney or potassium retention. There are certain medications like ASI and ARBs that are going to block the ultimate production of aldosterone. If aldosterone keeps sodium in water and pumps out potassium and H+, if we're blocking aldosterone, the potassium is going to build up. We have potassium-sparing diuretics like spironolactone and eplerenone that by themselves block the action of aldosterone. We also have things like triamptorine that can block the ENaC channel, right, and then lead to an elevation of potassium that way, right? Because if we're pumping sodium in for one potassium out, if I block that channel, we don't get that, and my potassium will end up building up. Okay. Because normally when we reabsorb a sodium, we pump potassium into the urine. And in this case, if we're blocking that system, we're not pumping as much potassium into the urine, so it's building up in my bloodstream. Okay. I highlighted in reds like NSAIDs, heparin, and TMP. Things like calcineurin inhibitors too can also cause it. That's because like when I was doing like UWorld or AMBOSS, I remember getting questions on like NSAIDs, heparin, and TMP causing hyperkalemia, and I didn't even know that was a thing. Now I know, right? So NSAIDs, heparin, and TMP, they're classically asked, so make sure you're on the lookout for those. Type 4 RTA, so we have a diabetic patient with who are classically have some sort of low aldosterone or resistance. And again, for the like millionth time, aldosterone keeps sodium in water, pumps out potassium or H+. So if we have low aldosterone or we have aldosterone resistance, the potassium builds up. Transcellular shifts. So in acidosis, right, when the acid level builds up, we have a lot of these potassium H+ exchangers all throughout our body, like especially in the kidney. When the H+ builds up, our body senses that increased H+ and it's going to try to drive it into cells, right? H+ is positively charged, potassium is positively charged. So if we're driving H+ into the cells, your body is going to try to maintain electrical neutrality, and it's going to pump potassium outside, out into the extracellular space, which can cause elevated potassium. So you probably memorized at some point that like acidosis can lead to hyperkalemia, and alkalosis can lead to hypokalemia. Now you know why, right? Increased acid out in the space Your cells sense that it drives H plus in, and in exchange of the H plus, it drives the potassium out to maintain electrical neutrality. Insulin deficiency, so insulin upregulates the sodium potassium ATPase. I just told you we pump 2 potassium in. If I lose my insulin, like I'm in DKA, then we can't drive that potassium in. Potassium builds up in the outside of the cell. I'll do a whole lecture on DKA because that deserves a one for itself as well. But so insulin deficiency is a classic cause of at least extracellular high levels of potassium. There's pseudo hyperkalemia. So look for the cells that are hemolyzed on the sample, right? Because when the cells get hemolyzed, it releases all of its intracellular parts, and that can lead to a falsely elevated hyperkalemia. It's not a true hyperkalemia. Leukocytosis and thrombocytosis can actually lead to pseudo hyperkalemia as well due to lab artifacts. And then there's exogenous loads, so like supplements, salt substitutes. Are the patients getting IV potassium and they have underlying kidney damage? Okay, high risk diagnoses not to miss, things like adrenal insufficiency. So again, if we have primary adrenal insufficiency, absolutely, right? Primary adrenal insufficiency, damage to the adrenal gland itself. There goes my glomerulosa, my fasciculata reticularis, and my medulla. Aldosterone is made in the glomerulosa. If I lose aldosterone, then my potassium builds up. Okay, cortisol also has mineralocorticoid properties at super high doses, right? So if I lose cortisol, that as well can potentially contribute. In adrenal insufficiency, you might see hyperkalemia, you might see hypotension because cortisol sensitizes the alpha-1 receptors on my vascular endothelium. Without that, norepinephrine is not able to work as well. Aldosterone also keeps sodium in water, so we're losing that piece of it too. Both of those can lead to hypotension. We can see hyponatremia. This is because cortisol inhibits antidiuretic hormone. When cortisol is low in adrenal insufficiency, we lose that inhibition. ADH goes wild. ADH causes translocation of those aquaporins. We keep water, we keep our solutes in the urinary system, right? And it can cause dilutional hyponatremia. And then hypoglycemia. Cortisol makes us insulin resistant. When I lose my insulin resistance, we can become hypoglycemic. Remember, you're not going to see hyperkalemia in secondary adrenal insufficiency. That's because in that case, it's a problem with my pituitary, or in tertiary, a problem with my hypothalamus. My adrenal gland is totally fine. Aldosterone responds to the renin-angiotensin system. It doesn't respond to ACTH, right? So in that case, only cortisol will be impacted. I did a whole lecture on adrenal insufficiency. It's in my video called The Rash That Wrecked the System. Go look at that. Tumor lysis syndrome, so look for a patient with like lymphoma or leukemia a couple days after chemotherapy was initiated. This causes this chemotherapeutic agents cause massive lysis of all of these cancer cells, and these cancer cells are going to release a lot of potassium, a lot of phosphate, a lot of uric acid, and then their calcium is actually going to be low because calcium gets bound up by phosphate in the gut, and calcium can also deposit into the kidneys. So the free calcium is usually low, and the potassium, uric acid, and phosphate are usually really high. Okay, so look for a patient really just starting classically lymphoma, just starting chemotherapeutics. Their potassium sky high, uric acid sky high, phosphate is sky high because they're all getting released from the inside of the cell. Calcium is usually low because calcium gets bound by phosphate in the gut and it can deposit into certain tissues. Okay, and then massive tissue breakdown. So things like rhabdomyolysis, crush injuries, or burns can all lead to cell breakdown and the release of potassium. So all some really important causes of hyperkalemia. So now we're getting into the final portion of the lecture. When do we treat hyperkalemia? So hyperkalemia should be treated when there's EKG changes. We've talked about those already. When there's symptoms attributable to the hyperkalemia, so such as like muscle weakness or paralysis. When the serum potassium is severely elevated, so usually above 6, 6.5. It really depends on what you're reading, but 6 is probably a good marker, even in the absence of symptoms. And then immediate treatment is also indicated if there's a rapid rise in potassium, or if the patient has certain comorbidities that increase the risk of complications. So if they have like CKD, heart failure, or ongoing tissue breakdown. So again, EKG changes, symptoms, when the potassium is severely elevated, like usually 6.5 level. And then if they have a rapid rise or they have underlying comorbidities, that the hyperkalemia would further worsen. Okay, so how do we treat hyperkalemia? This might be the most important slide in the entire PowerPoint, right? Because this answers our question that we were asking, and it's going to answer the question that they're going to ask you on your USMLE Step 2 exam. So first things first, we always do cardiac membrane stabilization, okay? That's with either intravenous calcium gluconate or intravenous calcium chloride, okay? This is going to stabilize the cardiac membrane because when we have super high hyperkalemia, it causes the threshold potential to lower. By giving calcium, it's going to bring our threshold potential back to normal and hopefully prevent us from getting into an arrhythmia like VFib. Okay. So, first things first, we're going to give IV calcium. Okay. So, you get a patient who's got elevated potassium, like above 6, above 6.5. They've got these EKG changes and they ask you, what do? You give them IV calcium. The IV calcium is not going to do anything to their potassium level, but it's going to protect their heart. It's going to protect them going into VFib and then sudden cardiac death. Okay. Uh, Once we take care of that, now we consider shifting the potassium intracellularly, right? First things first, we always do insulin with glucose. That's going to be our most powerful agent. So insulin is going to work really fast, right? And remember, it upregulates the sodium potassium ATPase, so we'll pump potassium into the cells. Okay. We also give glucose because if we just give them straight up insulin, they could become hypoglycemic, right? But the insulin is going to work pretty dang quick. Okay. Beta 2 agonists also upregulate the sodium potassium ATPase, but man, we have to give a huge amount of nebulized albuterol. Okay. This would be an effective option, like if we can't get IV access for some reason and we can't then give regular insulin, right? Regular insulin is only given via IV. So this would be a great option if we can't give IV regular insulin for some reason. But this super high level of albuterol can cause a lot of side effects like tachycardia, tremors, can cause neurological manifestations, right? So it does not come without risks. So really, insulin with glucose, number one. We can consider sodium bicarb if they have, on top of this, they have metabolic acidosis, but it's really less effective. It's never first line. Um, so now we've stabilized the cardiac membrane, we've shifted the potassium intercellularly. Now let's remove the potassium from the body, any excess that's left, right? So we can do loop diuretics like furosemide. That's going to work in the thick ascending limb. It'll block uh, potassium sodium 2 chloride cotransporter in the thick ascending limb, right? We have to just make sure their renal function and volume status would permit for this. We can give potassium binders. So there's the old one, sodium polystyrene sulfonate. It's not really recommended anymore for acute management because it takes a while to work and it can cause GI problems. There's newer agents like patoramur and sodium zirconium silosiliciate. This one is called Lokelma. That's the one we use at like my institution. Um, these are much better. They're going to bind the potassium in the gut. They're potassium binders, and then we poop them out. Okay. And then we can consider hemodialysis. It's used for refractory or life-threatening hyperkalemia, especially if the patients have renal failure. Now, the problem with all of these is they take a while to work, right? Think about how long it takes to get a patient set up to dialysis. These take hours for them to start working, and loop diuretics are going to take a while to work too. So these are like third, right? So again, treatment in order. Whenever you get a patient with hyperkalemia, like in a hyperkalemic crisis, right? We talked about the reasons why. So they've got symptomatic hyperkalemia. Their potassium's like above, I would say like 6, 6.5. It's starting to creep up there. We're seeing the EKG changes, right? We need to treat them, right? We're going to do cardiac membrane stabilization with either IV calcium gluconate or calcium chloride. That's always the right answer on your exams. If they haven't done anything to the patient and they say, what's the next best immediate step? Okay. Then we're going to shift the potassium intracellularly. Usually our go-to agent is going to be insulin with glucose. Okay. We could potentially use beta 2 agonists. We could potentially use sodium bicarb, but insulin with glucose is by far the best option. Then we're going to remove the potassium from the body. This can be with loop diuretics, potassium binders, or hemodialysis, or a combination of them. Okay. So a final word, I told you at the beginning, right? There's a bit of a nuance between calcium chloride and calcium gluconate. So calcium chloride delivers more elemental calcium, and it's actually the preferred agent in cardiac arrest. But it's more caustic and should only be given via a central line, not a peripheral line, because it can cause some tissue necrosis. Calcium gluconate is safer for peripheral use and is standard for most hyperkalemia emergencies. Okay. Um, I already mentioned this, but like the mechanism of action. So again, calcium gluconate or chloride does not lower serum potassium. It restores the normal difference between the resting membrane potential and the threshold potential. It raises that threshold potential, like I said earlier, and it stabilizes the myocardium. So it reduces that excitability. This action occurs within minutes and lasts for 30 to 60 minutes, and we can repeat the dosing as necessary. So on this question stem, like there was obviously like if they had to be asked, they wouldn't be able to give you both calcium chloride and calcium gluconate as an answer option. That's just not fair. That's controversial, but it's just kind of for your own learning. And in real life, we have to give calcium chloride via a central line because it's very caustic, and that is our go-to for cardiac emergencies, right? Cardiac arrest. But calcium gluconate can be given via a peripheral line and is really the standard for most hyperkalemia. Calcium chloride is the go-to for cardiac arrest because it delivers more elemental calcium. In our patient, right, he has been having PEA for a while. They don't currently have a central line in, although calcium chloride would be the better option because he's in cardiac arrest, he's in a PEA. We'd have to weigh the risk and benefits of like, do we want to take the time to put in a central line, or should we just hook up a peripheral IV and give him calcium gluconate, right? Those are kind of what you have to think about there. So a final word, part two, just because this lecture would not be complete without it. What are our indications for dialysis, right? There are A, E, I, O, and U mnemonic. So A would be acidosis, right? So metabolic acidosis refractory to medical therapy. The literature states usually we can consider this when the pH is less than 7.1. Electrolyte abnormalities. We really already talked about it, right? It's going to be classically your hyperkalemia. After we've done cardiac membrane stabilization and we've tried to drive potassium into the cells, then we consider hemodialysis. Intoxication. So certain drugs or toxins can be dialyzed. So things like lithium, ethylene glycol, methanol, and salicylates. Volume overload or pulmonary edema that hasn't been responsive to diuretics. Okay, let's get that fluid off via dialysis. And then uremia, right? So uremia can cause encephalopathy, pericarditis, and bleeding diatheses. All could be really, really traumatic if like in the right circumstances, right? So uremia that isn't able to respond, that's not responding to medical management, also an indication for dialysis. So let's put it all together with one final case. We have a 45-year-old man with a 10-year history of HIV/AIDS who presents to the emergency department with progressive muscle weakness and palpitations. He reports no chest pain, but notes that over the past 3 days, he has had increasing fatigue and muscle cramps. 3 weeks ago, his infectious disease specialist started him on a new medication after his CD4 count fell to 175. He's otherwise stable and fully adherent to his medication regimen. He's on tenofovir. He's on dolutegravir, atorvastatin, lisinopril, and omeprazole. On top of the new medication he was already started on. Here's his vitals. So his blood pressure looks good, heart rate's good, normal mental status. He's a little bit weak, no focal neurological deficits. His potassium 6.8. His creatinine's 1.4, which is elevated. His BUN's a little bit up. On the EKG, we see peak T waves, but we don't see QRS widening or sine wave. The patient is giving intravenous calcium gluconate immediately to stabilize the cardiac membrane. So my question for you is, what is the next best step in the management of hyperkalemia? So these are like the classic step questions I love because a lot of students are really good at that first step. But then they get into themselves into trouble when, oops, the vignette already gave me that step that I knew. Do you know what to do next, right? So you always have to think one step ahead, right? So this guy has hyperkalemia. I want you to also think about, why does he have hyperkalemia? Okay, think about if you can figure out the mechanism. We gave him intravenous gluconate, right, calcium gluconate, because he had an elevated potassium 6.8 and has this EKG changes and is symptomatic, all indications for it. But now you have to consider what's the next best step. So take a second look. You can pause your screen. So this patient has really high severe symptomatic hyperkalemia, likely precipitated by TMP SMX. So his CD count was less than 200. That right there is indication to start TMP SMX prophylaxis for pneumocystis jirovecii, which is an opportunistic infection that classically impacts patients when their CD4 count gets less than 200. You classically see like the bilateral interstitial infiltrates on the lungs. Look for a patient with immunocompromised or HIV/AIDS. We start TMP SMX to hopefully prevent that, right? TMP blocks dihydrofolate reductase. SMX blocks dihydropterate synthase, right? It's a great drug. Unfortunately, this TMP portion of it can also block the ENaC channels. So when you block the ENaC channels, we don't get the reabsorption of water or of sodium. And when I don't get the reabsorption of sodium, I don't kick out potassium into the urinary system, into the tubular system, right? These are in our principal cells. So if I'm blocking that channel, the potassium builds up, up, and up. This patient is also on an ACE inhibitor, right? ACE inhibitors are going to stop the conversion of Ang1 to Ang2. Ang2 is what triggers the release of aldosterone, right? So if I don't have that, I don't have aldosterone. Aldosterone keeps sodium in water, pumps out potassium and H+. So now the potassium is building up for a second reason. This patient is also on tenofovir. Tenofovir is known to cause renal dysfunction. So again, we started this new TMP SMX because the patient had the indication of a CD4 count less than 200. We need to protect, we need to have prophylaxis against pneumocystis, right? This TMP SMX is also prophylaxis if the CD4 count is less than 100, and that would be for toxoplasmosis. So we started the TMP SMX. The TMP can block the ENaC channels, less sodium reabsorption, and then less potassium excretion. So now the potassium builds up, up, and up. Okay. They were on an ACE inhibitor. ACE inhibitors are also going to lead to lower aldosterone level, so that potassium builds up, up, and up. And they might have underlying renal dysfunction from the tenofovir. And we actually kind of saw that with his creatinine being 1.4, his BUN being 38. So we already gave him calcium gluconate, which is the perfect next best step for stabilizing the cardiac membrane. Always the right answer if we haven't done anything to the patient on a board exam. Give him IV calcium, but we already gave it to him. So now my question was asking you, what would you do next? And all of them are feasible options. But remember, I told you the next best thing. Step 1, stabilize the cardiac membrane. Step 2, drive potassium into the cells. So that's our next step. Which one was the best out of the 3 I gave you? Insulin with dextrose, sodium bicarb or beta-2 agonist, right? Insulin with dextrose is by far going to be the quickest one to work, and it's going to work the best. So we do that. Then you have options like removing potassium from the system, things like loop diuretics, potassium binders in the gut like Lokelma, and hemodialysis. So those are going to be used more for like hemodialysis for sure for refractory cases or renal failure. And then we'll absolutely probably start potassium binders and maybe furosemide, but those are going to take a long time. So I'm not prioritizing them in my management. It's cardiac membrane stabilization, drive the potassium into the cells, and then we can worry about removing the potassium fully from the body, okay? Whenever you get a question like this, they'll always have hemodialysis as an answer. Hemodialysis is a really intriguing option to a lot of students because you're like, oh, it's hemodialysis, right? That'll totally take care of this entire problem. Just remember, it's probably never going to be the right answer unless they give you a patient who's been treated with the proper steps and still has this refractory hyperkalemia. That's because hemodialysis takes so long to get set up and it takes a while for it to work. So it's probably not going to be the right answer on any board exam question, unless they're talking about one of the AEIRUs. But in terms of immediate hyperkalemia management, just one more time to solidify, cardiac membrane stabilization with calcium gluconate or calcium chloride. Remember, calcium chloride, central line, best for cardiac arrest, but it's caustic, so we don't want to give it peripherally. And then calcium gluconate can be given peripherally for most other causes of hyperkalemia. We'll drive potassium into the cell, usually with insulin plus glucose. Can also consider beta-2 agonists and sodium bicarb. And then we'll remove potassium from the blood or from the body, and that will be with furosemide, your potassium binders, and hemodialysis if needed. Okay. So if you have questions, contact me. This was such a high yield lecture. Potassium management, the causes of hyperkalemia, the causes of PEA, the treatment of hyperkalemia, how hyperkalemia shows up on an EKG, all super duper high yield. I promise you will get at least a couple of those on your board exam questions at some point, right? Either step 1 or step 2. So let me know what you thought about this lecture. Reach out if you want to suggest further topics.